For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Come in, Mr. Murray. Oh, I see you've got Kate with you.
Yes, that's right, Doctor. She's had an accident at school.
Oh, dear. Well, I'll bring you both in here and get Kate comfortable on the couch first.
Oh, good. I think she's in quite a bit of pain.
Yes, obviously, and she's looking very pale. Now, can you tell me what happened?
Well, she had a fall at school, actually. It was in her gymnastics class, and I don't know, I think she landed awkwardly in one of the practice exercises.
And how long ago was that?
Well, the school called me to pick her up, and I came straight here, so about an hour ago, I think.
All right. Now, before we go any further, how old is Kate?
She's 7.5, Doctor.
Is she on any medications at all?
Well, she gets occasional asthma attacks, so she uses a venter inhaler when necessary.
Okay, and no other illnesses?
No.
Now, looking at Kate's right leg, she does have a nasty bruise developing as well as some swelling, so I do need to take an x-ray. Well, I've got the x-ray results here, and it's a spiral fracture of the right tibia.
Oh dear, I was hoping it'd just be a sprain.
No, it's more serious than that.
I see.
Now, I've rung the fracture clinic at the hospital, and they've advised that we can't put a cast on while there is that swelling.
Right.
But they've asked me to put on a back slab cast while there is that swelling, and also a bandage to keep that in place.
I see.
Has she taken anything to relieve the pain yet?
No, not yet.
Well, I'll prescribe her a medication known as Pain Stop for children. It's specifically formulated for fractures and contains both paracetamol and codeine.
Right.
And it's in liquid form and fast-acting.
Oh, good. And how often should she take it, Doctor?
For her age, she can take 10 to 12 ml every 6 hours until the pain subsides.
And how long do you think that will take?
Within 48 hours. But I do want you to contact me if pain persists longer than this.
Will do, Doctor.
And the other thing is plenty of rest for the next few days. Now, we'll need to set Kate up with some crutches, and you can get them from the pharmacy across the road.
Okay.
Now, they'll make sure that they're fitted and adjusted to her height.
Okay, but she's only 7, and I wonder how she'll manage.
Well, you'll receive instructions from the pharmacist.
Okay, she'll definitely need that.
And they can also provide a DVD which explains how to use the crutches properly, including how to get up and down stairs. This will help her gain confidence.
Now look at question 4. Take notes on the first 48 hours. Now, Doctor, I'm worried about what I can expect now, you know. I mean, if she had another fall or knocked her leg.
Yeah, you're right. It's not fully protected at this stage until she gets the full plaster cast, so both you and Kate will need to take care.
I see.
And during the first 48 hours, you need to keep the leg elevated in order to reduce the swelling.
Right.
And encourage her to wriggle or move her toes as much as possible. This will help reduce any swelling.
Okay, I think I can do that.
Well, at night, when she goes to bed, put a pillow under her leg so that it remains elevated.
And is there anything else I need to be aware of?
Well, if she complains of tingling feeling, like pins and needles, that means the leg needs to be elevated.
Hmm.
And if she's in pain or can't be settled by the analgesics, then you need to give me a call.
Okay.
And finally, watch out for any numbness or loss of feeling.
Will she be able to shower with the cast on?
Well, it's important not to wet the cast at all. She can have a shower, but the cast will need to be wrapped in a waterproof bag and sealed.
I see.
And keep the cast away from direct heat, such as heaters, electric blankets, and so on.
Right.
And make sure she doesn't put any weight on her leg or the cast in the early stages.
Will it feel uncomfortable?
It may feel itchy, but she shouldn't scratch under the cast, as this can lead to skin irritations.
Extract 2, questions 13 to 24. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
So, Mr. Alexander, the physical exam's very consistent with some very bad back spasming causing the pain you're in today.
Well, I am in a lot of pain. I've been in a lot of pain for a little over a week now. That's why I went to the emergency ward, because it just was unbearable. So, and I'm not sleeping well neither from this.
Yeah, you're exhausted.
I am.
Pain. Yeah.
Extremely.
Well, this back pain we can treat with some medication for the pain, something for the back spasm as well, exercises, and a heating pad to make you feel better. Most of the time, back pain will get better with this conservative treatment.
Well, that sounds nice, doctor. I mean, it sounds okay, but what I was thinking is that maybe I should have an MRI done, because I think maybe something seriously is going on with my back. So,
tell me about that.
well, I'm concerned that something is seriously wrong, like I may have a pinched nerve or a slip disc or something, and I figured an MRI could at least show if that's what's going on, or roll it out, and, you know, be sort of like a peace of mind thing for me as well. So.
Yeah, yes. I can see you're worried about it, and I would be too. But I have to tell you, the physical exam today shows nothing more than the back spasm. It has none of these red flags we worry about, such as the weakness in the leg, problems with the reflexes, or anything with this neurologic exam. It all came back normal today. You had no fever in the history, and no problems that besides the pain that you're having from the lifting that you described. I know you're in a lot of pain and you're worried about it, but most of my patients get better with this conservative treatment. Is there something else you're worried about?
Oh, well, like I said, you know, it's been a problem for over a week now, and I'm really concerned that something is wrong and that I'll never be able to work again, or I'll be disabled for the rest of my life.
Yeah.
I mean, doctor, look, I did some research on my own. I went on the internet. I was reading up about, what people do for their back pains, and I saw this guy, actually I saw a couple people who swear that after an MRI their back feels a lot better, something to do with the magnetisms, I believe. It's in the machines or something.
Okay.
And I hear people using magnets to help with back issues and other pains. So I'm thinking, well, I can find out if something seriously is going on with the MRI, and at the same time maybe feel better because of the magnets that are, going on in the machine. So that's why I'm asking you to give me a referral so I can get an MRI done.
Yeah. I know you want to get better. I feel that from you. But the MRI has not been shown in the past to help alone, the magnetism. That's not something that it actually does. It's an imaging study. It just shows what's there. You mentioned you wanted an MRI while we were doing the physical, so I pulled out some information for you about it.
All right.
Because the MRI can cause some harm. And we don't want to do that. It's unnecessary when you have this type of spasming pain. A study shows that with people who get MRIs within the first month of having back pain are 8 times more likely to have surgery. And I don't think you're a candidate or we want you to have surgery at this point.
No, I don't want surgery at this point. I don't want surgery at any point.
Right.
I just want my back to get better, and so I figured, this MRI could, show me if, anything's going on, and maybe the magnets would help. But you're saying that that's pretty much a myth.
No. I see back pain a lot, and most of my patients get better within 4 to 6 weeks with this conservative treatment we mentioned with the medication and exercises and heat. What do you feel about that?
Well, it doesn't look like you're going to give me an MRI referral, so I'll try it, but if it doesn't work or if I have other symptoms going on, could we consider an MRI then?
Absolutely. I want you to get better, and I really think this is going to help you get better, and you will get better. And if not, I want you to call me, and I want to see you again in a few weeks to make sure you're getting better.
That is the end of Part A. Now, turn over and look at Part B. Part B, questions 25 to 30. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. Now look at question 25. You hear 2 doctors discuss the transfer of care for a patient. Now, read the question.
Hello, Dr. Salvos. This is Dr. Broderick from the emergency department. I'm calling you with regards to an admission to the hospital medicine service.
Right, yes. Hello, Dr. Broderick. I'm the admitting physician for hospital medicine. Can you tell me more about the patient and why he needs to be admitted from the emergency department?
Sure. So the patient is a 68-year-old man with a past history of CHF, DM2, and a chief complaint of shortness of breath for 3 days. Chest x-ray shows a right lower lobar pneumonia. His vital signs are normal, but his BUN is 36.
I see. It sounds like he meets CURB 65 criteria for an inpatient admission. Have you started him on any medications in the emergency department?
Yes, we have given him supplemental oxygen and started him on breathing treatments. He will also be getting empirical antibiotic coverage. If there are any other orders you'd like me to place, let me know, and I'll do so.
Question 26. You hear a speech pathologist talking to the wife of a patient who has recently suffered a stroke. Now, read the question.
I just don't really understand why my husband can't speak properly anymore. Is it a result of brain damage?
Problems of this type are a result of damage to the brain, yes, but it's important to note that these issues haven't affected your husband's intelligence.
No, of course. I know it's still him. It's just frustrating when we can't talk like we used to. Will he get better eventually?
Your husband has shown improvement already, and we're confident that this will continue with regular sessions and practice. Patients tend to show the greatest change within the first 6 months, which is why we've planned such an intensive schedule for him during this time. We're confident that we'll see great strides in your husband's condition over the coming months.
Question 27. You hear a trainee doctor asking a senior colleague about chest tubes. Now read the question.
I'm still just a bit unsure about chest tubes. I was hoping you might be able to give me a bit more information.
Okay, sure. So, you know about the 3 chambers on the chest tube, right?
Yep, there's the collection chamber, the water seal chamber, and the wet or dry suction regulator.
Right. So, as the air from the pleural space passes through the water seal chamber, you should see gentle fluctuation in the water every time the patient breathes. This is called tidling. If you notice that tidling is no longer present, the tubing may be kinked or obstructed, or the patient's lung may have re-expanded.
Okay.
You should also make sure the chest drainage unit remains below the level of the patient's chest at all times.
Question 28. You hear a pharmacist talking to a customer about pain relief. Now read the question.
Hello, can I help you?
Yeah, I get terrible backache, and my friend said you could give me some codeine for it.
Do you have a prescription from your doctor?
No, but I don't want the full-strength stuff. I only need the weaker one. You know, they mix it with ibuprofen or paracetamol, so it's not as strong.
Okay. Well, first of all, there's been some research done recently that suggests that low-dose codeine doesn't offer much more pain relief than paracetamol or ibuprofen alone. We're not actually authorised to provide codeine without a prescription anymore, so I'd recommend picking up some alternative pain relief from the first aisle by the front door.
Question 29. You hear a trainee nurse receiving feedback from his tutor. Now read the question.
How do you feel you handled the patient's concerns?
Well, I think I was okay. Maybe I wasn't as confident as I could have been. I'm still quite nervous about advising patients. I guess I just need more experience to gain confidence.
Maybe, but I actually don't feel that was an issue for you. Do you think there's anything else you could have done for the patient during your examination? Well, you could perhaps have tried to be more reassuring rather than just stating the facts. Sometimes patients need to feel like their anxieties are being heard.
Yeah, I actually think I did cover this with the patient, though. He talked through his concerns while I was examining him.
Well, it's not enough for the patient to say they're feeling worried. You have to show that you're listening and reassure them that you're working with their best interests in mind.
Question 30. You hear two doctors planning their patient care schedule. Now read the question.
We have 24 patients in total to see today across 2 bays, and unfortunately we only have 4 staff members. I think we should divide ourselves into 2 teams. Would you agree?
Absolutely. Also, I think we should see patients according to their national early warning score. That way we'll get through all those who have urgent requirements before lunch. Then we can be sure that the most pressing investigations are performed earliest, and the sooner we get those organised, the better. Phlebotomists will be coming to the ward at around 1:30, so any blood forms should be given to them then.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B or C which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36.
You hear a GP, called Dr. Georgia Sims, giving a presentation on the subject of social prescribing. You now have 90 seconds to read questions 1 to 6.
Hello, my name's Georgia Sims and I'm a GP working at a practice in a small country town. My special interest is community mental health and my presentation today is on the subject of what's called social prescribing. I've been involved in a community health project which has been using this and which seems to be making a difference to the well-being of some of my patients. The project was inspired by the recent initiative that encourages GPs to include social prescribing in a patient's therapy. GPs are now able to write a prescription that allows a patient to attend one of a number of activities, each of which focuses on sociability and the feeling of belonging to a community. The activities encourage patients to link in with non-medical sources of support in both indoor and outdoor contexts. When I first heard about social prescribing, I had some concerns, but I was still keen to explore how it might be of help to my patients who suffer from moderate levels of depression and anxiety. I identified 3 long-term patients who often spoke of loneliness and feelings of isolation in addition to their mental health issues. But I was a little worried that the effect might be to reduce the input of GPs in patient care and cut back on the amount of direct contact GPs have with them. But after reading about various social prescribing projects that had been underway for a while, I realised this wasn't the case. Indeed, I began to see that my having the ability to prescribe a social activity would be helpful to my patients. Although there are several activities that lend themselves to social prescribing, like walking or singing in a community choir, I decided to go with a gardening project for several reasons. I'd already been contacted by the manager of a well-established community garden, which is tended by volunteers. Unfortunately, some volunteers had recently moved out of the area and more needed to be recruited. The garden is located close to public transport, which was an important consideration as none of my patients are able to drive for medical reasons. My hope was, of course, that the activity would improve their physical health. I'd previously encouraged them to try Keep Fit sessions, but this hadn't been a success. But I also hoped that being out in the fresh air in a non-threatening environment would have a positive emotional effect on them too. I was cautiously optimistic about the benefits to my patients of becoming involved in the gardening project. However, I was concerned that the hard work involved in digging a garden might be a daunting prospect for some of them, particularly those who had physical limitations related to health conditions. For example, one patient had undergone knee surgery the previous year and was understandably cautious about digging. Another patient has chronic back pain and was therefore unable to bend or stoop down. It was important to make sure the project manager was aware of their limitations and could tailor the activities to suit the patient's abilities and reassure them that the activities were indeed within their capabilities. After the first month of the project, I spoke to each of the 3 participants individually and was pleased by their feedback. All reported that they were enjoying an enhanced sense of well-being. They all admitted that when I first talked to them about the gardening project, they'd not expected to enjoy being out in the fresh air as much as they eventually did. This was the most welcome news for me. All other attempts I'd made to get them involved in such activities had been unsuccessful. One patient added that he left the gardening project each week feeling that it was a job well done. And I was very happy to hear that all 3 felt they had more self-confidence and felt that the future was brighter for them as a result of taking part. It all boded well for initiatives we might go on to set up. Looking back, I realised that I'd been unnecessarily sceptical about prescribing activities that were already available in the community. After all, I'd reasoned, people have been able to join all sorts of community projects on their own for a long time. Why would a GP's prescription make a difference? Something that one patient said, however, brought home to me the value of social prescribing. When I asked him how he felt about being involved in the gardening project, he said, "Without your gentle push, I'd never have considered it." When I asked him to explain, he said that it was like any other prescription I gave him for his condition. He trusted my expertise and viewed my social prescription as another part of his treatment. This, above all, has convinced me that social prescribing is a valuable addition to a range of mental health therapies.
Extract 2, questions 37 to 42.
Here in the health report, we cover all sorts of research. The Mediterranean diet, what fat is right for you, how much salt is safe, diets to protect you from diabetes, early death, heart disease. So this next segment is actually a bit perturbing. We're being told that almost all this research is wrong. Yes, John Ioannidis is Professor of Medicine at Stanford University, and he says the scientific approach taken by nutritional researchers is nowhere near rigorous enough, and we have to go back to basics if we're to learn anything significant about how diets impact health.
Thank you for inviting me.
Now, we've had you on lots of times before, talking about various things and demolishing a few iconic areas of health and research. You're arguing that nutritional research needs radical reform. On what basis do you say that?
Well, there's clearly a factory of papers being produced in nutrition epidemiology in particular that don't meet very high standards of credibility. The type of research that is being done in nutritional epidemiology, it's not an issue that there's bad scientists involved in it. You know, maybe excellent scientists are involved in it, but the odds of getting it right are extremely small.
Let's look at that in a moment, but you quote in your paper some really bizarre conclusions that you might come to from if you've believed past nutritional research. Do you want to just tell us some of those bizarre findings and their relation to either longevity or shortened lifespan?
Most of these studies are not experimental. They're not randomized. They're just observing people who report what they eat, and they take that seriously, that this is reflecting exactly what they ate, which is one major assumption. Second, people take these behaviors and these numbers as causal, which means that they look at the numbers and they translate them to an effect of these nutrients or of these foods on mortality. And then they also make another assumption that these risks are applicable to the entire lifespan. So then, let's take a number like 15% relative risk reduction in mortality or 15% increase in survival, which is the typical number that comes out of these studies. And this is the number that is the summary of all the data, for example, on what is the benefit with eating 12 hazelnuts a day. If you translate that to a gain in survival, you take 80 years, you multiply that by 15%. This looks like a 12-year gain in survival just by eating 12 hazelnuts a day, or literally one hazelnut a day would give you one more year of life as a benefit. It's a ridiculous calculation. It is not so, of course. Even if you believe that one of these foods or one of these nutrients or a couple of them may be important, it's impossible to believe that every single food, every single nutrient will have such tremendous benefits or such tremendous risks.
So you get there because of there's multiple levels of unreliability. Is that what it is? That essentially the food diary is unreliable, they're not controlling for other factors such as education and other environmental factors properly, and they all conflict together to give you bizarre results? Is that what's going on?
Exactly. It's a problem at multiple levels. It's an extremely difficult field to study. And it doesn't mean that observational studies, that epidemiological studies get it wrong all the time. In many other fields, the problems are much more straightforward. For example, we know for sure that smoking is killing zillions of people. It will kill 1 billion people in the next century unless we do something. But the effect of smoking is huge. The risk increases 20-fold if someone is smoking for getting lung cancer.
But just to challenge you on that, whilst we're confident in smoking, why are we confident in smoking and not in coffee? Because there have been no randomized controlled trials of getting people to smoke and other people not to smoke. I mean, so that's still on observational studies, is it not?
The major difference with smoking is that the effect is tremendous. We're talking, as I said, of a 20-fold increase in risk of lung cancer, 10-fold increase in cardiovascular disease. Many other diseases have tremendous increase in risk. For each single nutrient, each single things that we eat or drink, the effects, even if you take these studies literally, are much, much, much smaller. And based on what we know from some randomized trials that we have done, the effects are pretty much close to null, if not exactly null. I mean, it's very likely that they're exactly null, which means that it's a complete waste to even try to pursue them any further.
What about...
We cannot really use epidemiology to study a relative risk of 1.01. We can do it to study a relative risk of 20, which is what's the case for smoking.
And just to dissect that out for people don't know the statistics, is that 1.01 is, there's no effect, 1.01 is just tiny, whereas 20, an effect of 20 is 20 times the risk. So 1.01 is just a little bit over what would be normal and probably within normal limits. So what about eating patterns? I mean, you yourself have been involved in trials of the Mediterranean diet.
So I think that eating patterns, in theory, might be able to get you a little bit of that complexity of all these nutrients interacting together. But even those are very difficult, if not impossible, to study within an observational context. Again, you have most of these problems operating. Number one, you need to ask people what type of eating pattern they're following, and responses may be accurate or very often may be very inaccurate, especially if you try to recall what you ate and tell what you're doing. Just try it to yourself and see whether that information would be reliable. The second problem is that you still have extreme complexity among all these nutrients. We have over 200,000 different foods that you can combine in different ways. There's no clear eating pattern that each one of us is following. We follow different eating patterns in different periods of our lives and different days even. And it also changes all the time. If you superimpose the way that we react to all of these chemicals that we digest, our metabolic profile, also our genetic profile might affect how we react. Circumstances, our environment, socioeconomic factors that dictate what we decide to eat or not eat, and what we do or don't do with our life at the same time. It's an extremely complex system.